The Assembly Subcommittee 1, Health and Human Services, for May 5th, Cinco de Mayo, is now called to order. I want to welcome you all here. For our agenda, we have a number of issues, not an extensive agenda, but one obviously extremely important. We're going to begin, obviously, with issue number 1 from the Office of State Health and Planning and Development. I'm going to ask them to come forward to make the presentation.
Good afternoon, Madam Chair. I'm Robert David, Director of the Office of Statewide Health Planning and Development. We have 2 spring finance letters to go over with you today, and joining me is Lupe Alonso Diaz, who is runs our Healthcare Workforce Development Division.
Thank you.
Good afternoon, Madam Chair. The first spring finance letter is with respect to the WET Workforce Education and Training 5-year plan. This spring finance letter aligns future statewide MHSA WET appropriations with the second 5-year plan, which is 2014 to 2019. It does this by reducing the appropriations for local assistance by $3.449 million and increasing the state operations by $3.949 million. It also requests additional MHSA fund expenditure authority to fund 3 limited-term positions for 5 years at $330,000 in fiscal year 14-15 and $306,000 annually through fiscal year 18-19. As you may know, pursuant to the Welfare and Institutions Code Section 5820, in 2008, the Department of Mental Health developed the first WET 5-year plan. It is required statutorily. That first plan was April 2008 to April 2012. The plan, in essence, guides the statewide investment strategies for the mental health workforce system within the community public mental health system. The WET program was transferred to OSHPD in July of 2012. And the fiscal year 12-13 Budget Act allowed OSHPD a 1-year extension in terms of the development of that plan. OSHPD developed and employed a robust stakeholder engagement process. It included research and evaluation, county needs assessment, as well as stakeholder engagement process. In essence, the spring finance letter before you today aligns the stakeholder feedback and priorities from all of those forums and stakeholder interviews, et cetera, as well as the research with alignment with this proposed plan. In essence, this budget aligns the remaining $114+ million into statewide funds for fiscal years 14-15 through fiscal year 17-18. There are a number of strategies, 7 to be exact, in terms of the specific strategies for the development of the public mental health workforce. They include recruitment and retention, financial incentives, educational capacity, consumer and family member employment, regional partnerships, as well as evaluation. The second component of the spring finance letter is with respect to workload, and we are requesting additional staff as the new workload is not absorbable. We respectfully request your consideration. Thank you, Madam Chair.
Thank you. Are there any reports from LAO or Finance concerning this matter? Okay, no comments? Okay, fine. Are there any witnesses in support? The others? Any opposition? Okay, very good. Thank you very much. I don't think anyone has raised any concern concerning these items, and you've had quite a robust stakeholder meeting, quite a bit of input, which is really a good thing to do in order to make sure that the proposal is a strong proposal. I'm recommending approval of the proposal. Once we get a quorum, we will vote for that. So thank you very much. Let's go to item number 2. I believe that's also your item as well.
Thank you, Madam Chair, and thank you for that feedback. Madam Chair, member of the committee, this second spring finance letter redirects $700,000 from our existing California endowment grant to other programs that are also in alignment with supporting the development of the healthcare workforce. This proposal is supported by the California Endowment, which is our funder. As you may know, with respect to the California Endowment grant, the California Endowment invested or is planning to invest $52 million over 4 years to OSHPD's healthcare workforce development programs. Of that amount, there is $7 million authorized per year for OSHPD's Song Brown program. This specific spring finance letter proposes a redirection to the total of $700,000, $450,000 for California Student Resident Experiences and Rotations in Community Health, otherwise known as the CalSearch program, $100,000 for mini grants, and $150,000 via reimbursement contract to the California Department of Public Health for a fellowship program. As noted, this is supported by the California Endowment, and this redirection continues to support OSHPD's direction with respect to the affordable care communities, as well as other healthcare workforce initiatives that we have.
Thank you. Any comments from the finance or LAO? Okay, fine. Any comments from the committee? Okay. Any support, affirmative, any community support for this one? Any opposition? Sounds great. Okay, I do have a quorum now, and I can have the roll call.
Weber.
Here.
Chesbro. Here. Dickinson. Here. Grove. Mansour.
Okay, we're going to go back to issue number 1 that was presented. I'm recommending the approval of the spring letter requesting reduction to local assistance of $3.4 million and an increase to state operations of $3.9 million, an increased MHSA fund expenditure authority of $330,000 in 2014-15 and $306,000 annually thereafter through 2018 and 19, and a 3.05-year limited term position. So that is the issue. Is there a motion for approval? So moved. Second. It's been moved in second. Roll call.
Weber.
Aye.
Chesbro. Aye. Dickinson. Aye. Grove. Mansour.
Okay, I'm also at issue number 2 recommending approval of the spring finance letter requesting approval to redirect $700,000 in the TCE funding from the Song Brown program to CalSearch, mini grants, and a public health fellowship program. Is there a motion? It's moved in second. Roll call.
Weber.
Aye.
Chesbro. Aye. Dickinson. Aye. Grove. Mansour.
Thank you very much.
Thank you.
That moves us to the Department of Health Care Services, and we're going to have the LAO, I believe, make that presentation concerning autism services in Medi-Cal, also the PACE program and the Medi-Cal renewals. 3 issues underneath 4260, Department of Health Care Services.
Thank you, Madam Chair. Ross Brown with the Legislative Analyst Office. We are presenting a proposal, and I do want to make clear that this isn't our proposal and it's not the administration's proposal, but we've been asked to present it to you.
I understand.
The proposal would be to add applied behavioral analysis, or ABA services, as a Medi-Cal benefit. Just as some background, ABA is an intensive behavioral intervention therapy which is designed to promote positive social behaviors and reduce or ameliorate behaviors which interfere with learning and social interaction. The National Institutes of Mental Health, Surgeon General, and American Academy of Pediatrics have endorsed ABA therapy as the clinical standard of treatment for children with autism spectrum disorders. Currently, certain children in Medi-Cal are eligible for ABA services through the regional centers, but services are not available from Medi-Cal managed care plans. State law mandates that commercial insurers cover ABA services, but Medi-Cal managed care plans are exempt from this requirement. For several months prior to the transition of children from the Healthy Families Program to Medi-Cal, certain children were able to receive ABA services from Healthy Families Program plans. As a result of the transition, some children lost access to those ABA services. Advocates propose making ABA a covered benefit under Medi-Cal, regardless of regional center eligibility. And if it pleases the chair, we do have just a few comments that we'd like to make on this proposal. In light of the state's improved fiscal condition, we believe the legislature should make building a reserve and paying down debt and other budgetary obligations high priorities. We also believe it'd be reasonable for the legislature to consider making some targeted budget restorations or program augmentations that it considers to be a high priority. In our view, it's reasonable for the legislature to make adding ABA services to Medi-Cal managed care a high priority. We note some important factors that the legislature may want to consider about this particular proposal or augmentation. First, adding ABA services as Medi-Cal benefit would make it consistent with commercial coverage, where the legislature has already made ABA services a required benefit, thereby making coverage consistent across payer types, which could enhance equity and improve continuity of care as children move between coverage sources. Also, there appears to be some legal uncertainty about whether ABA services are a required benefit under federal Medicaid law. While we don't have a formal legal opinion on this matter, This legal uncertainty is another factor that the legislature may want to consider as it weighs this proposal against other program augmentations that it's considering. While there are some strong arguments to be made for prioritizing ABA services, the legislature must still weigh the merits and likely costs of this particular proposal against others it's considering. In doing so, it's important to note that there continues to be significant uncertainty about the costs associated with adding ABA services to Medi-Cal. Thus, some of the existing fiscal estimates may need further examination and refinement as the legislature considers how to prioritize its budget resources among many different options that it's considering. And we are, as an office, are happy to work with staff and help analyze some of these estimates and refine some of the estimates as the legislature moves forward in its deliberations. Thank you.
Does the department have any response to the three questions that we've asked? Cost estimate, reasons for anticipated difficulty in terms of the federal financial participation, and so forth and so on.
Sure. Madam Chair, Mary Cantwell from the Department of Healthcare Services. In terms of a cost estimate, we do not have an updated version of the estimate that we provided last year, really because of the variability of the information that's out there. We haven't found any sort of new information at this point that would cause us to update that. It was a wide range of potential financial impact. We have been asked to provide technical assistance to the legislature in updating that estimate, so we are seeking additional data to try to provide a more refined estimate. I do want to note that depending on the structure, what delivery system it would be a part of, who would be eligible, all of those things would impact what the potential fiscal estimate would be and would vary depending on what the final proposal might look like. In terms of the second question, for purposes of Medi-Cal, we are required to follow federal rules pertaining to the Medicaid Act for covered services and the receipt of federal funding. In our discussions with CMS on the matter of ABA in the past, they have indicated that as a discrete service, it's not a specific covered benefit under Medicaid. However, under the Medicaid Act, participating states must provide early and periodic screening, diagnostic, and treatment services, otherwise known as EPSDT, for Medicaid-eligible beneficiaries under the age of 21. The EPSDT program mandates 4 specific categories of services: screening, vision, dental, and hearing services. And additionally, there's a catch-all EPSDT mandate that the state provide to Medicaid-eligible minors any other necessary health care, diagnostic services, treatment to correct or ameliorate defects in physical and mental illnesses and conditions discovered by screening services. So that's really where the crux of the issue is at this point and where the courts have been looking. For ABA to be provided through Medi-Cal, the department would need to submit a state plan amendment that would contain the guidelines around eligibility for services, utilization controls, eligible providers, including licensure, reimbursement, and which delivery system we would be looking at. In addition, if the benefit were to be provided through Medi-Cal managed care, the department would need to amend our 1115 waiver, our managed care contracts, and our capitation rates. And finally, we are watching closely what's happening in Washington State. There is a state plan amendment that has been submitted by Washington State that was developed as a result of a settlement of a lawsuit on this issue. What we have learned is that the proposed state plan amendment characterizes ABA services as preventive services. So should CMS approve the Washington State plan as currently drafted, it is certainly possible that these types of services would be considered EPSDT services.
Okay. Any other comments from any of the staff? Okay.
Yes, good afternoon, Madam Chair, members of the committee. Carlos Quant, Department of Finance. As this proposal is not part of the governor's proposed budget, we have significant concerns with expanding benefits at this time. Providing these services would have a significant fiscal impact to the extent that they become required due to what's going on in Washington. We'll continue to monitor what's going on and evaluate how the outcomes will impact California.
Okay. Do you have any comments on the issue of equity with regards to the children who have benefits and those that don't?
I mean, obviously, when the legislature passed the bill to add ABA to commercial plans, there was a specific exemption for Medi-Cal managed care. So obviously, that was a decision at the time. If the legislature wants to make a different decision, obviously, we would follow suit with what we need to do.
Has anyone done any discussion or analysis of the long-term impact of these services in terms of cost benefit over time? In other words, you've got an issue here that supposedly from the material that I've read basically creates a different environment for children later on, that they need fewer services in terms of special ed, fewer interventions, those things that can be very expensive. So even though there's services provided here, if not, then you would provide even more services later on. Have we done any cost-benefit analysis of the kind of services that could be provided?
The department has not.
We have not.
Madam Chair, could you direct that question to the LAO as well?
LAO, have you done any financial analysis?
No, we have not. We have not.
Is it? But I assume that most of you agree, and based on the information we have, that these services are very important early in life. I assume. Well, you can say yes. Okay. I assume that they are beneficial, and that the evidence and the research shows that children who engage in this early on don't need as many services later on. So I think sometimes when we talk about the benefit of something immediately, we fail to look at the long-term impact in terms of the cost factor that's involved in terms of being having either more remediation, plus just in the humane sense of the quality of life. I mean, if I get out of the money story and get into the human story, you talk about a person's life that improves dramatically as a result of early intervention. We can talk about it on the money side, then we have to talk about it on the human side in terms of what would happen, for children, and then the equity issue of those who get the services and those who don't. You see the dramatic change in their life. So I'm just curious as to whether or not in any of your analysis you've done the benefit analysis as well as the human analysis, but more importantly the benefit. This is finance, so the benefit analysis of immediate investing and long-term benefit. So, yes, my colleagues.
Well, you nailed it very well, so I'll try not to be repetitive, but it's been 5 or 6 years since the since the beginning of our current budget crisis, and we had to pretty much drop the ongoing critique of the budget process, which was that we never look at how an expenditure reduces future deficits. Mm-hmm. We might, 6 months or a year down the road, but certainly not that a child is not going to grow up and go to prison, or something that's going to benefit a budget 20 years from now or 25 years from now, or the economy's better because a person's in the workforce. But I think it's time to revive that discussion. So I really appreciate you bringing it up, because I think this is a very good example. And my critique of the entire budget process, so I won't single anyone out, is that we have such a very short-term view of things. And I think the governor's encouraged us to take a longer-term view, and our leadership has in the Assembly to put a rainy day fund in place. That's very prudent. But I think it's also prudent for us to be asking the question, when we spend $1, how much contribution is that going to make to future deficit reduction? Because it's every bit as important as putting money in a rainy day fund. So it's not always fair to have that be the criteria, because there's lots of humane reasons to do things. But when you have the overlay of both the humane reasons of making somebody's life better, but also saving the taxpayers' dollars, then I think we ought to do the analysis. And I welcome the opportunity to reignite that discussion.
Sounds good. Mr. Dickinson.
Thank you, Madam Chair. I just couldn't agree more with the sentiments you both have expressed. And it's the kind of analysis that doesn't consider what future benefits may be, fiscal in this case, that leads us to have a set of budget priorities that moves more and more money at trying to fix things after they're broken, as opposed to investing in preventing the harm in the first place. And it's much more cost effective as well as effective for institutions and individuals to not have a problem, as opposed to try to repair it after it occurs. So I know that there are always reservations expressed that we can't do that kind of analysis. We don't know what will really happen. But unless we do get back to that kind of analysis, we'll continue to make short-term decisions that end up being foolish financially and otherwise long-term.
So I add one more comment?
Yes.
Thank you, Madam Chair. I know from all those long discussions we've had in the past that one of the critiques of that analysis is, well, if that's the criteria, then everybody's going to come in and prove how they're an investment in the future, so it doesn't really help you differentiate. But I want to point out that in this item we're talking about a program that has been endorsed by the National Institutes of Mental Health, Surgeon General, and the American Academy of Pediatrics for the preventative benefits that that would be provided. So it does. So there's, I think, some pretty firm. Unlike that broad generality that says, oh, all lots of kinds of spending or investments in the future, but I think in this case, it's pretty clear cut.
Okay, thank you. And of course, I'm sure we've all seen the statistics that the number of children identified with autism is increasing immensely. So it's something that we want to try to get a handle on if we can and be proactive rather than reactive to the things that are happening. Do we have any comments, public comments in support?
Good afternoon.
We'll each have a minute.
Good afternoon. Holly Lane Bean on behalf of Children Now. We're in support of putting the autism services in for Medi-Cal. We would just like to note that the state requires ABA coverage for all kids except Medi-Cal kids whose families are in most need of services and resources. ABA is endorsed as a clinical standard care of treatment for kids by many well-respected groups like AP and the Surgeon General, and ABA therapy is also very cost-effective, and we believe it will cost the state somewhere in the realm of $18 to $37 million general fund. Thank you.
Thank you.
My name is Faye Al-Maliti, and holy smoke, I just want to give all you guys a hug because that is the most thoughtful discussion I've ever heard on ABA in the legislature, period. I have a 9-year-old son with autism. His name is Mohammed, and we don't live in San Diego. I wish I did. But ABA therapy has helped my son. We know what the numbers are like. You know, when my son was first diagnosed, it was 1 in 50, and that was just 5 years ago, and now we're 1 in 68. That means your grandkid, your niece, your nephew, and unfortunately, one of you guys' children is going to have autism. So we need to do something, and we cannot have 2 different classes of kids. It can't be that because I can afford private health insurance that my child gets treatment, and for someone who needs help from the state can't get that treatment. They're the same kid. It's the same kid. And if you don't pay now, you're going to pay later. Thank you.
Karen Fessel, Autism Health Insurance Project. I have a 19-year-old son with autism, and I just want to say that the Regional Center covers a small percentage of children, and so they're only paying for a very small percentage of children that need this treatment, and so they're not getting it there. Last year, I had to hold the hands of many families as they lost treatment, and it was a very painful process. There are several other states, about 15, that currently offer ABA through Medi-Cal, and we are usually leading the pack in terms of progressive reforms, and this is something that we need to be leaders for. We're a leader for the nation, and America turns to us and to see what's going on in California. We can't afford not to wait. I think you guys have amply made that argument. Money spent today is money that is going to be saved not like when these kids grow up. It's going to be saved when they hit school, when they hit kindergarten. They're going to need fewer supports, and that's going to save us, the state, special ed dollars. I think the best way to manage this is through EPSDT, because we're going to have the least negative impact on being able. It's going to be the most advantageous to setting up networks that way. And okay, that's it. I'm done. Thank you so much.
Good afternoon. Eva Terrazas. I'm Director of Public Policy at EMQ Families First. We're a statewide children's behavior and mental health organization. We are offering autism services in our San Bernardino area. One of the things that we have found is that many of the children coming through are children who were on healthy families, transitioned on to Medi-Cal, and no longer are having the service. They're not qualifying for the regional center, and so the number keeps growing every month of the children that are trying to come through the program. I want to commend the committee for the thoughtful questions that you asked. I think it is important to talk about short-term gains and long-term benefits, and I think there is something important about the type of particular services for children with autism. ABA has been proven to reduce the level of severity, or at least get children to a point where there's a diminish in terms of services in the future. So thank you.
Thank you.
Hi, Kristen Jacobson, Autism Deserves Equal Coverage, and the Alliance of Healthcare, Alliance of Autism Organizations. Thank you very much for the thoughtful discussion today. I agree very much with the points about equity. ABA and Medi-Cal is the only benefits, the only mental health benefit that is carved out of our Medi-Cal essential health benefits that we include in Covered California. Otherwise, we adopted the identical plan with the exception of behavioral health services, which we define in law as autism services. In terms of the savings, I will forward to Andrea and anyone else who would like. There's a study out of Harvard that shows that between $650,000 and $1 million per individual who receives early intervention is saved over their lifetime, ages 3 to 55. That is not an insignificant figure, and if you multiply it by our population, that's $39 to $64 billion that we're talking about potentially savings. And then in Texas, there's a study that shows $208,000 net savings dollars per individual for early intervention. That's $12 billion in special education funds. 40% of kids who get the treatment can be mainstreamed without support in kindergarten. Another 40% have substantially reduced services. The state, when they passed the emergency regulations for healthy families to get the coverage, they documented and found that any denial or delay of the services would likely cause irreparable serious harm. And so now we have established that, and yet we are knowingly causing serious irreparable harm to all these families in Medi-Cal. There were 2 families that testified last year at your hearing, Rachel Harris and Jasmine Wilson, and they lost their service. One of them lost their services. One of them never had it. A year later, they still don't. Thank you.
Thank you.
Thank you. Melissa Cortez-Roth, representing Autism Speaks. We also believe that ABA is covered under the broad EPSDT mandate. I do want to comment briefly on 2 things that have been raised. First is the carve out of Medi-Cal in the broader mandate, the insurance mandate. It wasn't just Medi-Cal, it was also Healthy Families and CalPERS, and the Department of Managed Healthcare later did emergency regulations to make sure that those 2 areas were also covered. Kristen already mentioned that when they did that, they said it would cause permanent and irreparable harm by not doing that. So while the legislature did carve out 3 specific areas, 2 of those are now covered. It's just the one that's remaining. And on Washington, I am happy to hear that the department is watching closely what's happening with their state plan amendment there. But it's my understanding that they're actually covering ABA in their Medicaid system today, and they're not waiting for approval of that SPA. Thank you.
Thank you.
Good afternoon, Michelle Stoll-Parvensky, Children's Defense Fund California, also here on behalf of the California Children's Health Coverage Coalition, and we support including ABA services as part of the Medi-Cal Managed Care Program. I really appreciate the comments about the importance of early intervention, both for children's long-term development and for saving money for the state in the long term. In addition, as was previously mentioned, in the Healthy Families transition that happened last year, previous to that, there was a number of assurances from the administration and from the legislature that no children would lose access to essential services, but we know that children did lose access to ABA services, and so we would urge you to make right on that by ensuring those children have access to services as well as all children in the Medi-Cal program. Thank you.
Thank you.
Madam Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty. Also appreciate the discussion and concur with my colleagues. As a legal matter, we're a legal organization. We do believe that ABA services are required under EPSDT and the Medicaid program, and is the only consumer advocacy organization that supported the administration in the transition of Healthy Families kids to Medi-Cal. We feel a moral imperative to appear before you and say you've got to put these benefits into Medi-Cal. It's frankly disgraceful that our lowest income children are the only people who don't have access to these services. We know the chairwoman's very aware of the impact of this, and we urge the legislature to take action. Thank you.
Thank you very much. Okay. Any comments in opposition? All right. I want to thank the staff for that. Thank my colleagues. This item will be held open for consideration for the budget. The PACE is the next item. I want to welcome our budget chair, Nancy Skinner, for this item. We will hear concerning PACE. Yes, LAO, yes.
Thank you, Madam Chair, members of the committee. We've been asked to present this proposal by the programs of CalPACE, an association of programs for all-inclusive care for the elderly. This is not a proposal by the administration, and the proposal is fairly new to us. We don't have an official position or recommendation at this time. PACE programs provide integrated acute and long-term care services to beneficiaries who are 55 years of age or older and who meet criteria for nursing home placement. PACE programs receive capitated payments for these services. Per existing statute, PACE capitation rates are to be paid at no less than 90% of the amount that DHCS would have paid for the same services under the fee-for-service program. This amount is known as the upper payment limit, or the UPL. The CalPACE Association is requesting trailer bill language to increase the rate from 90% to 95% of the UPL and to require DHCS to implement a rate formula in a way that evens out variations in rates across different counties for the PACE programs. DHCS estimates that the budget impact of increasing the UPL payment from 90% to 95% would result in costs of $14.6 million total funds or $7.3 million general fund. Thank you.
Okay, any comments from?
I'll just respond to the question that's in the agenda. The department has previously proposed language for this purpose in prior budget years that has been rejected. Our proposal has simply been to remove the current UPL methodology and add PACE to the same section of law that governs our experience-based, actuarially sound rate methodology for all our other managed care plans. We strongly believe that a move to an experience-based methodology is needed and would resolve the concerns of the PACE organizations because it would be based on their actual cost experience. It would also ensure that the situation that occurred with SCAN would not occur here, where overpayments were being made because experience-based data was not being used. Additionally, one of the issues that the PACE programs have raised in their proposed trailer bill is the concern around not having comparable fee-for-service data in counties anymore now that most of the population has moved to managed care. And we concur that that is an issue, and we really think moving to an experience-based methodology would then get away from us having to have this UPL-based methodology. We have wanted to move to this methodology, experience-based methodology, for the past couple of years, and really believe that our focus is really best spent on doing that and working with the PACE organizations. We do have a work group with the PACE actuaries, and we're really hoping that that work group can focus on this idea of moving to an experience-based methodology instead of continued focus on the existing methodology that, at the end of the day, we think is flawed.
Okay, comments?
Thank you, Madam Chair. Scott August, Department of Finance. Department of Finance is opposed to this proposal as it's not included in the administration's fiscal plan. As indicated by the committee agenda, the proposal would cost approximately $15 million total funds, $7.3 million general fund, which is not accounted for in the governor's budget. In addition, as previously stated, the administration has been working with stakeholders to develop actuarially sound experience-based rates that will better align with the actual costs experienced by PACE programs. The proposal before the subcommittee today is inconsistent with an experience-based approach and would preempt the development of a more appropriate rate methodology. For those reasons, the Department of Finance is opposed. Thank you.
Okay. Comments from the committee? You're recommending an experience-based, which means every time they go in, they get paid. Is that what you're talking about?
So it would be the same as what we do for our existing managed care plans. So what they do is they report to us what their Medi-Cal costs are through a rate development template. This is what we do with all of our other 21 managed care plans. And we would then use those costs, their historical experience, and trend it forward to pay them based on their own actual experience. So we would be developing prospective risk-based rates, which they're paid now, but right now they're based on a fee-for-service UPL for a comparable population instead of actually looking at their actual Medi-Cal cost experience of the plan to use that to set their rates.
Okay. You anticipate that would save money?
I don't think we know at this point. I mean, we don't have the data yet from the PACE organizations. Certainly the concern that we're hearing from the PACE organizations is that the rates that we're paying them now are not covering their costs, and so an experience-based methodology should resolve that, but there's also been pushback to moving to an experience-based methodology, which we find curious, and so we really think it's worth the effort to actually go through developing the data reporting that's necessary, have it helping the PACE organizations understand how they can report the data and moving forward with that.
Is PACE a program that saves us money?
Certainly, we think the PACE program is an important program and provides, as was presented by by Felix that it's an integrated program that we think is very good for this population. But obviously we also have our coordinated care initiative now that will be moving forward in certain counties that we also think will be saving us money. It's a similar sort of structure of having sort of a fully integrated Medicare, Medicaid plan. So definitely think it's a worthwhile managed care program.
Okay. Is our Medicare, Medi-Cal plan dealing with our most fragile? I'm curious.
Yeah, so the Coordinated Care Initiative deals with all dual eligibles and integrates long-term services and supports into their managed care and integrates their Medicare benefits into the same plan as well.
Okay. We can hear from those who are here. I had the good fortune to visit a PACE program, so it's very unique, saves us probably a tremendous amount of money, but also enhances the quality of life for those who are in the program. Seeing from where they've come to where they are, the kind of support that they get. I'm not sure if we get it in other services in terms of the coordination. I think that's maybe our goal with our other programs, but they obviously have developed a track record of providing the wraparound services that really enhance and change and impact individuals' lives. People able to walk again who barely got out of wheelchairs before, but now have all these services that are really very, very important. So it's kind of like a model of what we think we want to become, I think, in terms of services that are provided for our most fragile and oftentimes those who have very few resources in terms of family support to assist them. So it's really, it's an interesting program, interesting concept, one that obviously provides a tremendous amount of services and assistance, physical, mental, social, all those kinds of good things. So it's really interesting. Yes, Ms. Skinner.
Thanks, Brandon. Appreciate your comments. I felt like I was hearing some contradictory information because your presentation was that the experience base would give a more accurate read on the costs, and yet Department of Finance basically maintained that opposed to the recommendation or to their PACE request of increasing the rate from 90% to 95% because it would have a cost of about $7 million more in terms of general fund. And yet what you raised is that a experience base may cost more. So if we're looking at potentially moving to something that costs more, and yet the basic rejection of what's on the table is because it costs more, I'm having a little hard time. But before you answer, and the reason is because right now we have many of our PACE programs that are hardly being able to make ends meet, and some are at risk of closure because the payment structures we put them under, which used a combined, it wasn't just a nursing care eligible population, it was nursing care eligible population plus non-institutionalized individuals who use home services. We mixed that, and yet PACE, as we know, only provides for as Ms. Weber indicated, more than nursing home eligible. In other words, the highest need of our frail seniors. So it's a very different population mix. And it seems to me that if we want PACE to function in the way that prevents folks from being in a nursing home, which was its purpose, it's going to cost us more than what we're paying right now because we're seeing now that, and we had the recession and such, but that we put those programs in jeopardy.